An assistant professor here in the Department of Neurosurgery. I'm also Associate Director of Neurosurgery at Elmhurst Hospital, and I have the honor of talking to you during this session about the designing the C1-C2 arthroplasty. We'll see what some of the current concepts and challenges in doing so. To begin, I have no disclosures to report relevant to this talk. As a brief outline, we will look at the normal C1-C2 anatomy and function. We will consider the idea of motion preservation, what that means, and what scenarios we've been able to achieve that. We'll also look at some specific challenges to motion preservation at C1-C2 and current concept and current designs that have already been suggested for performing in a C1-C2 arthroplasty. To begin, here we have a lateral x-ray which shows the 7 vertebrae which make up the cervical spine. Even from this initial image, you can see that C1 and C2 look quite different from, say, C3 or C4. But within the spine, the adjacent vertebrae interact with each other through an intervertebral disc anteriorly or through facet joints posteriorly to allow motion. And the summation of the motion at each level will in turn be the allowable movement of the neck. And if we look broadly at the cervical spine, we'll see that we have a large amount of motion that is allowed, 80 to 90 degrees of flexion, approximately 70 degrees of extension, lateral bending, this is trying to touch your ears to your shoulders, is roughly 20 to 45 degrees. In rotation, this is turning your head left to right as if you're shaking your head no, up to 90 degrees in each direction. Okay, of course, there's going to be a lot of variability between individuals, and within an individual, as one ages, there can be decreased range of motion. Okay, but these are some good approximations for what normal range of motion of the cervical spine is. Invariably, there are surgeries that we perform that take away motion. So in this image, this is what we'll call an occiput to C4 fusion. The occiput is just a region of the occipital bone that forms part of the skull. And in this image, we see there's metal hardware that attaches to the skull, then also attaches to the top of the cervical spine. Where before you would have motion between the skull and the first vertebra, and then between C1 and C2, and C2 and C3, and so forth, we no longer have motion between these levels. There are instances where we are able to preserve motion, and we have data and experience that suggests that when we're able to preserve motion, it is likely better for the patient. So in the mid-cervical spine, we have a variety of creative solutions to preserve motion. And on the right of this image, we see there's several implants that are available that allow for motion. And conceptually, there's different designs, but they all have the intended result of trying to mimic physiologic movement across an intervertebral disc, at the same time constraining the motion so that you don't have any unsafe motion that compromises your spinal nerves where they exit at that level, or more seriously, your spinal cord. But as we can see, going back to this x-ray, C1 and C2 are very unique and look very different from your mid-cervical spine. So the solutions that we have work well in the mid-cervical spine. And when I have patients that are candidates for cervical arthroplasty or motion preserving surgery, I'm very happy to offer that as a solution. But we certainly also want to be able to offer solutions for C1 and C2. But the anatomy, even from this x-ray, as you can see, is quite different. So if we take a closer look here, we have image of the C1 and C2 vertebra, and they're so unique in regard that they have a special name. C1 we refer to as atlas, and C2 we refer to as axis. And there's reasons behind those names that we don't necessarily have to get into right now, but suffice it to say that they are atypical vertebrae with unique structure. These are the articulating surfaces of C1, and these are the articulating surfaces of C2. They're relatively shallow or flat, and that can afford a lot of motion. Okay, so if we then move on and we look at how C1 rests on top of C2, the shallow or flat articulating surface really allows for a lot of motion, and the primary motion that we use in our day-to-day life is axial rotation. So where C1 is rotating about C2, and the point of rotation is approximately along this process of C2 that we call the dens. Now the extent of movement can vary based on methods of measurements, but the axial rotation of C1 and C2 has been reported to be between 30 and 75 degrees. In general, you can take it as approximately 45 degrees of rotation to each side. And if you look at the entire cervical spine, roughly the C1-C2 accounts for 50% of the axial rotation of the neck. So you can imagine anytime we do a C1-C2 fusion or fix these two vertebrae with hardware, we are taking away 50% of the axial rotation. And this loss of rotation is more than at any other level in the spine. So if there was a good solution where we could preserve motion, even a fraction of the motion, it would be a welcome tool to have, in our tool bag. Conceptually, if we think about what would the ideal C1-C2 arthroplasty look like, or what would it require, the ideal arthroplasty would allow normal C1-C2 motion. It would also, just as importantly, constrain motion for stability. And when we talk about C1-C2, the main movement that we're trying to prevent is C1-C2 subluxation. So this is where the C1 vertebra is translating anteriorly relative to C2, and the consequence of that is that you can compress or injure the spinal cord. Of course, our implants, we would like them to be biologically inert. They have to be durable. If you put in an implant into a patient, it should last ideally, the lifetime of the patient. And of course, since we're talking about ideal scenarios, there would be no complications related to the arthroplasty, and it will have a technically easy learning curve. So the technique would have to be relatively familiar to surgeons for early and widespread adoption. Now, keep in mind that these are just my thoughts on what the ideal C1-C2 arthroplasty would have, but the reality is if we had a solution that was safe, straightforward to insert, very low complication profile, and even if it only preserves, say, 50% of the normal C1-2 motion, then that would be a large step forward in advancing this area. Well, if C1-C2 is so important, one question that might arise is, well, why don't we already have an arthroplasty? Why wasn't that the first area that was investigated, for development of an arthroplasty? And the answer, suffice it to say, is that it's challenging. So remember, when we look at the C1-C2 articulating surfaces, they're mostly flat. This allows translation anteriorly, posteriorly, and even side-to-side translation. And the joints can be stabilized also by joint capsules that help to reinvest and support the integrity of the joint. Well, C1-C2 has a joint capsule, but it doesn't meaningfully add to the stability of the joint. And the articulating surfaces, since they're flat, they're also not contributing to the stability of the joint. When we have an arthroplasty, because we have to ensure that motion is constrained to prevent unsafe movement, we're starting to see that we can't just mimic the shape of the C1-C2 joint. Now, if we carry this examination further, when we look at the C1-C2 joint cartilage, the cartilage is the coating of the bony articulating surface. We see that the cartilage on C1 and on C2 takes on this biconvex shape. So then as C1 rotates on C2, C1 is also sliding up or sliding down the slope of the C2 cartilage. And as you can see in the lower left, in this image here, as C1 rotates, also the joints are not moving in unison. One side of C1 is moving anteriorly, the other side is moving posteriorly. And so if you think about the shape of the cartilage, one side is moving up the slope on C2 while the other side is moving down the slope of the C2 cartilage. So this is adding in a tilt. C1 is tilting also on C2 as it's rotating. Okay, so this is another anatomic feature that again adds for greater movement. And perhaps you might say, well, this is too much movement. But the reality is, it's up to local ligamentous attachments that provide stability to prevent unsafe motion, right? It's not from the joint itself, it's not from the cartilage, it's not from a joint capsule. It's really ligaments that are actually providing the stability in this area. And if we examine the motion even further, very unique to C1, we see that there's no significant motion at C1, C2 that occurs by direct muscle attachment to C1. In general, a bone moves across a joint, or movement at a joint occurs when a muscle that attaches to a bone contracts. So while one muscle may cause a joint to flex, you can also have an antagonist muscle that is responsible for extension. At C1, C2, there's no significant muscle that attaches to C1 to cause movement. All right, so an analogy of this is, imagine you have 3 boxes stacked on each other, and between the lower 2 boxes, you put a set of tennis balls. Okay, and you apply forces to the top box and you apply forces to the bottom box. No direct forces are going to be applied to this middle box, but by virtue of it being able to freely move from these tennis balls between this box and the lower box, you'll see that as you apply forces to the top box and the lower box, you will encounter movement of the middle box. And that's not so unlike C1, C2, where the movement is not from any muscle that's pulling on the C1 bone to rotate it or to flex it or extend it. The motion really comes from muscles that are attaching to the skull, or muscles attaching to the rest of the lower spine, so C2 and below. And as those muscles are flexing and turning the head, C1, C2, that motion is subject to that external motion. And the consequence of that is sometimes where you are moving the skull or flexing the neck, sometimes you actually get extension at C1, C2, not because there's any muscles directly extending at C1, C2, it's just that is the motion that's occurring subject to motion outside of C1, C2. Now, so this arrangement is counter to what we find elsewhere in the spine. So again, in the design of an arthroplasty, we have to pay particular focus to constraining the motion such that only axial rotation is allowed. And we can see, based off this unique and sort of counterintuitive setup, it's not sufficient to just mimic the structure of the joint. Doing so, you may not, and likely will not, accomplish everything that you want to accomplish when we look at what are the requirements of an ideal C1-C2 arthroplasty. So now let's look at what are some of the current concepts and designs that have been put forward. One of the earliest ones is from the group Wang and others in 2009. They put in this concept, which consists of two main parts. One part that attaches to C1, the other part attaches to C2, and in thinking about allowing axial rotation, they have this hinge about this piston on C2 with these processes, metal processes that protrude out, and these help to constrain and prevent over rotation, so that you can have rotation of C1 over C2, and then these processes will constrain the rotation towards a normal physiologic movement, so approximately 45 or so degrees to each side. And also, by virtue of these screws attaching to C1 and C2, they're also going to limit and prevent C1 and C2 subluxation. And again, remember, that's preventing C1 from translating anteriorly relative to C2. Another design put forth by Zhang et al. In 2010, very similarly, comes from an anterior approach where you have two main parts. One part that attaches to C1, one part that attaches to C2. In their design, the C1 portion rotates along this hemisphere. Again, that allows axial rotation, and by virtue of this hemisphere and the screws supporting this part that goes into C1, it's going to help to limit C1, C2 subluxation. In 2013, Wang made a modification to their design, and so rather than have their rod that the C1 part rotates about, they included a spherical component to allow for greater movement, including a little bit of lateral bending as well. Okay, it still also helps to prevent C1-C2 subluxation. Now, these three designs require an anterior approach, which has significant morbidity and a substantial learning curve for most surgeons. An anterior approach in this area is not a routine procedure. It also requires resection of part of C1 and resection of part of C2. So again, remember, C1 rotates about C2, and that rotation occurs along the dens, which is that superior protrusion off the C2 vertebra. And so in these instances, and for this arthroplasty, they're resecting the dens, that's this open space, and that's where this implant sits. In instances where you have to do that, this is a very good design because your rotation is primarily around the dens. However, if you don't have to resect the dens, then it's adds additional complexity. And then also, again, the anterior approach is is not a common approach, is not as familiar to spine surgeons. In 2015, Dr. Goel wrote an article about designing an artificial C1-C2 joint, and in his approximation, he looked at a posterior approach, which again is more familiar to spine surgeons, and looking at rethinking the articulating surface. So his approximation, he approximates the joint as a ball and socket joint. Okay, and then so on both sides you have a bilateral insertion. He has these spikes along the surface helps to wedge and secure the implant in the bone at C1 and at C2. And as you can see in this image, this type of ball and socket design will certainly allow flexion, extension, lateral bending, but in his design, the ball actually is not capable of leaving the socket, which is good for preventing C1-C2 subluxation, but it actually does not allow axial rotation. But as we saw earlier, when you have axial rotation, one side is moving, translating posteriorly, the other side is translating anteriorly. All right, and so again, you really need to have free movement and constrained movement. And again, the two joints do not move in unison. Even they may mirror each other to some degree, but even they're not quite. Yeah. But the advantage of this approach, of this design from Dr. Goel, is that it's a posterior approach that's more familiar to surgeons, and perhaps this is one way to look at it, not necessarily a ball and socket joint because the C1-C2 joint can't be approximated as such, but a bilateral insertion of an implant that allows for axial rotation and preventing C1-C2 subluxation. Now, those are some of the current designs that have been shared in the literature. What are some of the next steps? Well, this is where you come into play. We will have a Q&A session to discuss what are the next steps, how can we improve upon and advance the design of a C2 arthroplasty. Perhaps we need to have a very different approach. Instead of looking at the joint or the articulating surface or looking at cartilage, perhaps we have to have a different approach to stability or constraining the motion. And I look forward to joining you then. Thank you.